We are good.
Yep, we're good.
Okay, perfect. Welcome everybody this is our 7th Facebook Live. I was actually uploading some things this weekend and to YouTube, and I was counting how many lives we've done, and we've done like 6 already, from the thorax to the knee to the foot to the neural tension, and now we're going to do the hip, which is relevant for me because I actually have hip pain. Well, I've had a long-standing issue with my hip, but and it's actually had gotten better, but I sitting home here hasn't helped, so I'm trying to rehab it and get on my Stairmaster. So it's definitely helping. So this is a personal Facebook Live as well for me. So I thought that we would start off with I'm just looking down here. Once again, I'll have an issue with my phone as usual. So, a lot of times I often get questions from patients on, whether they have hip pain or whatever. They're like, oh, my glutes are really weak. I have a weak hip. My glutes are really weak. And I'm like, yeah, maybe not, right? It doesn't necessarily, your glutes may not be weak. They just could be inhibited. And that may or may not be the reason why you have hip pain. But I'll just bring up somebody, a patient I had, and we can just sort of start the discussion. If anybody has any questions, they can certainly talk about it. I've not talked about this particular patient on our podcast. So open chain, main issue, anterior hip pain, basically just open chain hip flexion bothers this guy. That's really it, right? Maybe deep butt to floor squats, but really nothing else, just open chain and deep butt to floor squats. And with somebody like that, and I'd be interested in your opinion, Susan. He's like, well, do you think I have weak abdominals? Do you think I have an overactive psoas? Do you think my hip's the problem? Et cetera, et cetera. So before I even go through like the whole assessment, I often say, well, it depends. A lot of times people do have underactive abdominals and they overwork their hip, or they're working on their glute strength and they overactivate these deep external rotators. And to put it into Shirley Sarman's language, they'll have that femoral anterior glide syndrome, right? Or that femoral medial rotation syndrome that she talks about in her books and her courses. And with this particular patient, he definitely had that, very dominant bearing weight on that right leg. I mean, on that right side, he had right hip pain for years. And I often wonder why, he wasn't aware of his center of mass, but he could not lift his hip up an open chain without it aggravating, or do a butt to floor squat, closed chain, but really deep, like almost impingement like symptoms, right? So, in my assessment, I treated him as if he had a rotational issue. So I treated his thorax. However, and he got better, 80% better. But then he started to do other work. He was going up and down stairs more, that open chain hip flexion, and the hip really started to bother him. And I just got stumped there for a second, and I was like, why? Number one, it's an open chain movement, and that was a lot better, but he did more of it. And we did do a lot of rotation in the program, but I didn't address the hip initially because I didn't believe it was the driver, the source of the problem. It was definitely the pain generator. So I got him 80%, and then all of a sudden this issue came on, whether it was neural, whether it was motor control, or, was not articular. I was definitely an overactive muscles, rec fem, overactive TFL, things like that. So I'll stop, Susan, if you want to, mention or have anything to add.
No, I'm just interested to, if you don't mind backing up again.
Yep.
What was his squat like, and could he get on and off the floor? Could he do some of those deep closed chain movements without any issues?
Not deep butt to floor squat. He could do deadlifts and squatting pretty good, except he just couldn't go down, like literally. And he's super flexible swimmer.
90 degrees or more?
More. He could go below 90.
Okay, but not all the way down.
No.
Okay.
No.
And so what was his occupation? Does he sit a lot? Does he?
Student. He's a student, so sits a lot.
Sits a tremendous amount.
And sitting didn't bother him though,
But what does he feel like when he goes to stand up from sitting?
Fine.
As long as he's not below 90, he's okay.
Correct. And his main issue was the hip.
Okay.
Yep. Yeah. And
right?
yes,
So, and then when he went upstairs, just lifting the leg up to the stairs bothered him.
correct. Correct.
Okay, so going from that lengthened position into open chain flexion
Correct.
really
Correct.
bothered him.
Yes. And in any kind of, like he thought at one point he had like weak hip flexors. So, he was, from another therapist he saw, he was doing isometric hip flexion, which made him worse. I'm like, of course it made you worse. You probably overactivated your rec fem, your TFL, and your psoas to boot. And that's probably why it aggravated. So he would do, and he had seen somebody else prior. They would do like soft tissue release and, your typical sort of release type of techniques. And he didn't really get long-term better. It would feel better short-term, but he was very specific with the open chain and the deep closed chain. Everything else was fine except for like a one-legged standing on that side. And that's, another issue. I mean, another problem, but that was not what he came in initially with. It was really that classic hip flexion, And when I saw him, I thought, he was really compressed because he sits, and I did a little decompression. I basically got him off his right leg, centered him a little bit, and gave him some decompression in the thorax, tried to take out, because he's a hypermobile swimmer. So whenever he did any kind of lower movement, and because he was a swimmer, he would do like this in his thorax or this in his thorax, where we were translating one side to another. And so what ended up happening when he ended up lifting that leg, he would sort of deviate off to the other side. So right open chain flexion, he would really translate to the left. So when I got him centered, he felt better. So I went with that, and he got a much better. But when we started, and then we talk about this, when we started to load the system more, that hip was plateauing.
Okay, so so I just want to go back to the stairs. When he was going up the stairs, when he was lifting the leg up to go up the stairs, it bothered him.
Yes.
When he actually put the leg on the stair and lifted his body up, he was okay.
Correct.
No?
Correct.
Yes.
Correct.
Okay.
Correct.
Okay. So, and then this is a guy that's a swimmer. Does he have pain with swimming?
No.
Okay, so the water, no pain in the water. And
No.
so when he goes up the stairs and he deviates to the left as he picks his right knee up,
yes,
he was having more problems, right?
Correct.
Okay, so it doesn't sound like it's impinging, because it would be less if he deviated away from that hip, because it would open up the right hip.
Right.
So, but then he felt better when you when you brought him back over center, where he was swinging more true.
Yes.
So, it sounds like to me that, well, my first impression would be what's going on in his lumbar spine.
Yep.
Especially, and since you were working with the thorax and working with rotation, and if he's not rotating in the pool, which happens a lot with swimmers, they side bend rather than rotate, and they have trouble getting their face out of the water. So it becomes a problem. But if he's only side bending and he's not rotating, you're thinking about the hip, and you're thinking about L1, L2. I mean, that's neurologically kind of where things may be happening. There may be some irritation happening around that area. Maybe it's being side bent too much. Hard to say, but it kind of seems like a little bit more like that than, even though it's in the hip, we can oftentimes see thoracolumbar components with anterior hip pain.
Yes.
Because there's so much of that. And then the lumbar spine, especially L5, S1, the iliolumbar ligament also has input from the L1 area, so you can get ilioinguinal anterior hip pain, those kinds of things from that as well.
Yeah.
Do you have any other issues? Me, I'm going to start asking things like, did he have testicular pain? Did he have
no?
Did he have other, other things going on? Because sometimes you see that together, and and that kind of begins to make me kind of think, well, where else could this be coming from? So
yeah. So he did have a little bit. So He did have a little bit of some low back issues, but sometimes I think, and I'm like you, I'm like, well, does he have low back? He had a little bit of a SI joint, quote unquote, as he said. My SI joint a little bit a while ago bothered him, but he was doing a lot of extensions with that. And I was like, well, if you're doing a lot of extensions, this was with a prior therapist, you're doing standing extensions, you're thrusting your hips forward in a way that's going to may aggravate if you have any kind of anterior femoral head issues. You're doing a standing extension is going to make that worse. Not, it may help your back, but it'll definitely make your hip worse. So I told him to stop those because that was making his hip actual worse. So we stopped that, and I said to myself, because sometimes I we overanalyze. I tend to do that, right? It's my nature. So, but I'm thinking, is this just like a secondary hip issue? Am I not, we've got the primary area. Is this a basic, lack of motor control around the hip? He just overactivating rect fem and not using his lower abdominals. I mean, it's simple, almost as simple as that. So what I had him go against the wall with his feet up on the wall, like almost like in a tabletop. His hips were like 100 degrees of hip flexion. So I had him do some bent knee raises, literally with his feet on the wall, closed chain, and just do little bent knee raises with a small abdominal cue, very small. And he was able to do those very easily because it's gravity assisted, and he was able to get into that bent knee raise, hip flex posture with no pain. So I almost had to take it down to literally like eliminate the gravity, eliminate all the other stuff, and go back to basics almost with the hip, right? I find that, that really helped him to start.
Yeah. I mean, when you've got people who have there's a couple of things. Number one, are they sensitized? Is the whole anterior hip region sensitive? Is it sensitized beyond what maybe, something from the tissue? Maybe at once it did have a little bit of issue of, the tissue being the driver, the original nociopathic pathway, and now it's become, sensitized. So it may not be that tissues are being impinged anymore. It may not be that tissues are, but the nervous system is sensitive. And I think that, when you have something that shows up like that, is showing up in just a certain area in a certain way, I think we have to kind of begin, so this is a strategy that worked for him forever, and then all of a sudden it wasn't working. So he's symptomatic now. And we have to find another way to put some novel input into the system. So you're just doing graded exposure here, which I think is really great. You got him into some positions where he needed to move his hip in that direction, but he was doing it from a different perspective. And so that kind of begins to change the movement system, because he's not relying on the same pattern, which he was doing for just regular lifting to go up on the stair. He was doing it in a different way under different circumstances. And that begins to start to change how the brain activates and the other pieces there. And I think that that's super important, because, you just need to kind of back them off a little bit of what it is that's really bothering them, or help them find a new strategy so that they can do it without having the pain for the short term.
Right.
And then once they start getting better and they're less symptomatic, then you can start exposing them back to that
exactly.
stair climbing activity, or whatever, whatever other activity they are. So we have a question from the audience. Lindsay. Hi, Lindsay. Hi, Sue.
Lindsay.
Welcome.
Hey.
Lindsay says, do you think swimmers should power through thoracic or hip rotation? I'm not sure what you mean by power, but I will say that we need to make sure that there is actually rotation occurring. There are swimmers that, will not use a lot of rotational movements, and they really have trouble rotating their head. If they're not getting thoracic rotation, they end up over rotating their head up at the CV cervical, up at the higher part, the higher cervical spine to grab that rotation. And that can interfere with respiration, for long term. It's a great strategy for sprinting in the pool. It's not a great strategy if they're going to be doing longer types of swims. So because they need to be able to have much more of an even keel going, that's, you know, at a higher respiratory rate. So pecs are important. Lats, of course, are extremely important because you're looking at a lot of posterior chain activity to hold them up out of the water and to rotate them, but you're also looking at a lot of power through the arms and then the legs as well. So you get the anterior and posterior chain kind of working. And of course, it's opposite, you know, as they swim. And so I think that it, you know, so my question is that generally the people, you know, good swimmers are not real short, stocky people. Fast swimmers are real tall, like this guy, tall, and somewhat tend to be a little bit more on the lankier side, you know, those long muscles and that sleekness that just really glides through the pool so well. And so I think it's kind of a combination of what are we powering through something because we're not doing something else? So are we powering more hip rotation or more lumbar, you know, rotation down below, or over kicking down below because we're not getting a rotation up above? And if you're just really not getting that thoracic rotation, it's really hard to get the scapula up out of the water and the arm, you know, up overhead in those movements. And that it doesn't really matter if you're doing butterfly or overhead or even backstroke, you know, one of those things, the way that I've seen it. It makes a difference to really get that thoracic mobility. And I love the way that you went there with him because, you know, the decompression piece is kind of cool. That's like unweighting. So when people have hip pain, they have back pain, they have whatever, you know, sometimes we just need to, we want it to load, but we want it to maybe not load all the way. And you were doing it kind of for the opposite, though, because it wasn't loading that was bothering him unless he was going deep. It was like more kind of just unloading and helping his system find a different input, a different center. And, you know, and just getting that up, you know, kind of helped a little bit and helped him change, which is what made me think a little bit more about, you know, thoracolumbar rotation with him.
Yes. And for sure, absolutely. I think because of the you know, the real specific nature of his issue, open chain hip flexion, I mean, that is very specific and very deep butt to floor squats. And because he's a swimmer, because he's hypermobile, he wants to be able to do deep butt to floor squats. You know, God knows why, but he does. And that's fine with me, right? So, and yet he'll get that little impingement. My guess is just because of just the approximation and the deep nature of that squat. But it was really purely open chain. And he actually, when we were working the thorax and getting the rotation, the decompression, and I did push-ups, I did a lot of things with him. And I actually did squats because he could do squats. He could do squats really well. So I did add squats into his program, and then I added the rotation. And he really did well. But then he started to go upstairs more. I think it's something in his student, it changed buildings or whatever. And he had to do 5, 6, 7 flights a day and repetitively, and that flared him up. And that's not so much a load per se, but that's end range hip flexion a lot, many times. And I find that these little tricky issues, whether it's another area of the body or the hip in this particular case, whether because it's his area of meaning, that at end range, that got really irritated. And I had to literally, and I think with the hip is great, I took him down to like, well, what bothered him? How can I get that particular movement de-threatened? And, to get him in that right against the wall, like literally on the plinth, feet against the wall, just doing that. I had him do little bent knee fallout, same thing, all gravity assisted. And he really loved it. He said that was like a game changer. And I was like, that's basic, Susan, almost. That's basic hip work.
Yeah, I know.
Right?
But it's great, right? That basic stuff kind of works. I'm curious to know where you took them after that, because, I'm thinking of the various different ways you can get somebody to unload themselves while they're exercising and doing stuff. And, like so somebody who's having trouble, like going deep with a squat or having trouble at end range flexion, because that's what it is, right?
Yes, exactly.
End range flexion, end range flexion, end range flexion. And they want to squat, first of all, does it do better if they're like wide-legged or narrow-legged? What feels good? Where can they squat from that doesn't feel painful?
Hmm.
or less sensitive. And then, one of the things I like to do is have people use those big long bands that are stretchy, but they've got a lot of oomph to them, is that they can grab hold of those and actually lower themselves down, and it pulls them up as they're lowering down, so they can actually kind of start working on, as they're holding up,
Oh,
it's
like a,
lifting, as they're beginning to kind of come down away from it.
I mean, like a
So they can,
TRX thing,
yeah, kind
or
of like a TRX thing, or
uh,
even like a real heavy resistance band,
yes,
but they
yes,
hold it way up high,
yes,
so they get the resistance as they come down to
yes,
pull them up. And so you get kind of this like opening, and
yeah,
they can move to either shorter, bringing their arms down on it for less help,
yeah,
or they can move to a lighter band, that
yeah,
doesn't help them as
yeah.
much, to kind of get those in. I think another really fun way that I used to do this with the pulley system when I worked in Louisiana, but I don't have one of those now. The Scandinavian system, the pulleys and all the little bitty weights and
Oh,
everything. But I just kind of make it happen with a lot of, with the resistance bands and stuff, is get the resistance band up on something and then have them put their foot in it so that they push down.
mm-hmm.
So for the loading, they push their foot down just like he would on a stair. That's fine, he
Yeah,
can do that. But then as you lift up, you've got the assistance of lifting the leg up.
exactly. It's almost
So
like the Pilates box,
yeah,
which I did do
exactly,
with him. Right.
exactly. Or you can do it underneath the thigh, so it
Ah,
lifts the thigh up or lowers it
ah,
down, so
right.
you can kind of play with it wherever that tends to work. And that could be a really cool one to do too, that can actually get that movement system back in, but get it
Mm-hmm.
in a different way to where it's not as sensitive, and they can, they don't have the inhibition, that the pain is giving them, around that particular structure or somewhere else.
Yeah,
And then
yeah,
they can practice the, being on one leg and not shifting off too much, and just doing it different.
yeah, yeah.
I'm curious to know if you did the side to side, the coronal plane kind of
So
side lunges and side
I
slides and things like that with him too.
I did. He had no problem with that. He did.
Mm-hmm.
It's funny. So I did do that. I had him do like the star lunges and side to side lunges. He did all of that. And he did get on the TRX. I didn't do that, but in hindsight, that's a great idea. I don't remember. I may have mentioned it, but he didn't like have access to that. And I think using a TheraBand is a great idea.
Mm-hmm.
That's a great idea. I had him get on the box, the one to box, and had him just sitting, just doing like almost eccentric, like with the springs and sitting. And what was interesting, I did have him do the real deep. So when I started to have him do deep side lunges, I just wanted to test it.
Mm-hmm.
So it was his right hip. And so when he went to the left side, he was pretty good. When he went to do the right side to bear more weight on the right side, bearing in mind, he was standing from the get go on his right leg. So he was just getting over on a side that is his path of least resistance. And that aggravated him. It's just
Mm-hmm.
like, I don't feel so good in that position. And
Mm-hmm.
notably, the thorax, you know, doing lateral movement will challenge that part of region of the
Mm-hmm.
body, which is what I wanted to do, but I didn't want to flare the hip up,
Mm-hmm.
uh, to be honest. So
Yeah.
what I went back, so I took a step back again, and I had him in a bridge position. I had him in a bridge position, just getting into hip extension, and had him do one leg knee to chest in a bridge position. And he had zero problem with that. So
Mm-hmm.
that was just doing basic hip flexion.
Mm-hmm.
I didn't have him do bridges. I don't usually give bridges out, but I had him in the bridge position and
Yeah.
literally just literally one down, one, and just keep doing that leg. And he actually felt really good with that. So then
Mm-hmm.
he has a Swiss ball at home. So I had him literally go on his back on the ball and once again get it, do a pelvic, like just get your hips in extension and do some knee raises in that position, bent knee raise in that position. He felt pretty good because he was taking out that rec fem and the TFL, and he was in a position of extension. He did well with that particular. So I wanted just to stick to sagittal plane because it was bugging me,
Yeah.
that. So
Well, and you were grading the exposure in the sagittal
yeah,
plane, so you were doing it in different positions under different circumstances, with different kinds of requirements, which is what you know, like it was what you were doing with the side lunge. And I know that you probably, you know, once he said that bothers me, then you don't go so far.
No,
Like
exactly.
only go as far as you can go without it bothering you. Let's get this to where you feel comfortable here, and then we'll start getting to see if we can go a little closer and a little closer, snuggling up to the discomfort, but not pushing through it every time.
Yeah.
Especially when you had somebody kind of like this that's got this kind of sensitivity issue or sensitization issue, that you definitely want to like not have them not do the activity, but have them do it in different, under different circumstances, you know, under different, you know, it's just, you know, that whole novel input to the system,
Yeah.
you
And
know, things that,
yeah, yeah, no. And he had physical therapy before, and he was like, they mobilized my hip. And I'm like, well, you can do that, but you don't have a joint problem per se. You know, you can take the mulligan, the belt, and mobilize the hip, you know, for the sole purpose of maybe decreasing muscle tone or neural input to the hip, which is, I actually did that at one point. I mean,
or it increases it. You never know.
exactly. It depends. So, you know, you don't have a joint problem. It's just a matter of, you know, we all do like interventions for different reasons, but you know, you're not stiff and you don't have a joint issue, and maybe it'll reduce some muscle tone, but you have to train a new strategy. You can be belt mobed all day long, you know, unless you have an articular problem. If you don't follow up with meaningful movement or movement strategy in the same session, it's not going to help. And I have found that, and I think we've talked about this before, not just with hip patients, but if I take away their stabilizers, you know, especially these hypermobile patients, and you know, release or do whatever you do, and you don't train them in the same session, they're going to come back worse. And I've had that happen, you know, where you take away their stabilizing their capacity, and then they come back and I'm like, oh, you know, I didn't feel great, you know, because you didn't follow up with like a little squat. Or so with somebody like him, I actually squatted till the cows came home because he didn't have any problem. And so I was slowly getting him deeper to the floor without him knowing it, because I was doing it in the context of like, the end of the session, let's going to do this, and let's, you know, versus you do deep squats and let me know how it feels type of thing. So it was just, I was using it in a different way.
Yeah, and you started using it as a test retest.
Right.
Like, okay, let's do this now. Let's go back and do this activity. That's classic consumer comparison, as Eric Franklin would call it. You know, I just love that term by him. But that's exactly what that is. It's mindful movement too. It's like, how do you feel now? Do this stuff. Now, how do you feel again? And did you need me to put my hands on you to make a change there? No, you can do this. This is, so that becomes whatever it was that you guys did together can become kind of, you know, this is your classic test, retest, and then you reset, you know, okay. So when you go into a squat and it hurts, this is what you do. And then you go back and you go back to that squat. We don't abandon the squat, like never squat again, because I'm sure people have told him that. Don't squat. You're squatting wrong. You're doing this wrong in your squat or whatever. And it's like, no, it may not be that at all. It may be that they just need to be exposed to it in a different way, and they need to kind of look at things in a different way and feel it in a different way, and realize that they can actually make changes. Because we know that how the motor control system works is the more we actually add information to it, and it actually has to begin to start, it'll actually start changing the way it functions, you know. And so we have to see what the expression is. So you put all this input in, so it can be sensory, it can be thoughts, it can be context, it can be laying on his back instead of standing up and going up a step. It can be all of those different things. And what you look for is, how does that motor system, what is the emerging vector of that motor system afterwards? And you know, people get so caught up in this, it has to look like this. And it's like, you know, this guy, he may be just fine like that. He just needs to get the sensitivity down, be able to trust that he can do this thing. And I know that you talked a little bit about this in the beginning about glute activation. I just wanted to point out, there was a tweet out by Greg Lehman today, and I'd have to go back and pull it up, but they were looking at people who were painful and loading and people who were the controls. And they were talking about people with IT band pain, classic, what they would call IT band pain, whatever that is, pain on the side of the leg, I guess. And they I'm not going to do this research thing justice, but just go with me on this. But basically, they were doing loading exercises, and they were measuring the electrical activity of the glute max. And the people that were painful going underneath those loading things actually had excellent activation of their glute max.
I believe
So
it.
pain may not be as big of an inhibitor to the glute max as we think.
Interesting.
That it may be the position that we're asking people to work in is more important than whether they're, whether they've had pain or not. Because what the postulation of this was is that people with pain, we tend to actually treat them differently than people without pain. And we really shouldn't be doing that. We should be exposing them, just like you were talking about with this guy. His stuff was in the front, but it doesn't matter. We shouldn't treat him differently. We should just look at where is he having a problem and how can we begin to start to interact with the movement system around that problem instead of just saying, okay, well then don't do stairs for a while.
Right.
No, let's figure out a way for you to do stairs so it doesn't bother you.
Right. Exactly. Exactly. And, versus somebody who has, a subpopulation of some women, because I've been doing a little bit of research on this just for my own, benefit, who have these tendinopathies in this menopausal, postmenopausal population. I know there's some research going out of Australia, these women who have greater trochanteric bursitis in this postmenopausal population, that they're developing like tendinopathies because of hormone changes and things like that. And their hips really hurt. And it's the loading. And I find that I forgot who's doing the research. It's a woman in Australia, but it was fascinating to me because, as I said at the beginning of the live, I have hip pain and I'm in that group, right? So is it, for me, you need to progressively load a tendon, and you need to do that. And Soul Cycle for me is spinning that does load. I mean, when I first started spinning, my hip was killing me. I would limp out of the office there, this training center, and then it slowly got better. So, and the point is that, it depends on the person, whether you've got a true hip, and I wanted to bring the hip up today because once we haven't talked about it, but it's really, I'm seeing a lot of people with hip pain. And I think that it's not necessarily, somebody who's in their 70s who needs a hip replacement. It's not that at all. And it's, I get the same questions, are my glutes weak or my glutes strong? Do I need to work on my glutes? And it's always the glutes. And I'm like, and I'm going to look up that tweet today because that's fascinating. But with this patient, I didn't even like work his glutes. I mean, not directly. I mean, they were working in the squat, but it wasn't an impairment that I found on the assessment. And so for him, I ended up having him work a little bit of lower abdominal because I do believe that was not firing when he lifted his leg up in open chain. I do believe that was an issue. So instead of I moved him off the wall. And then I took him out of hip flexion at one point. I had him doing planks on the stairs just to get him in a different movement pattern, to get his abdominals going, to see if it would transfer over to open chain. So
exactly. And I also think your point about the hip tendinosis or whatever we want to call it, hip tendon degeneration, particularly in females postmenopausal, which it tends to be way more females than males. There's a hormone issue, obviously, but that, and so here comes the differentials. We need to really know what, a lot of people will talk about differentials don't make any difference anymore. And, you can't throw out the baby with the bathwater. You got to still understand the tissue that you're dealing with. I really think that you do. And part of this is that, okay, so a degenerative tendon is going to behave differently under loading than this guy's sensitive anterior hip. You're talking about, some differences here. And so what we know about tendinosis and loading is that it is painful, but it's also, if you understand the mechanism of what's going on, that it begins to change as we load it. It has to, unfortunately, it's one of the few things that you really kind of have to hurt a bit to get it better under the right circumstances. And, the literature is all over the place around the Achilles now, because now some groups of people, there's some newer stuff that's come out that do not respond to eccentric loading. They just don't. And, so you got to kind of like get them into gliding and moving and doing a whole bunch of other stuff. I think one of the things that's really favorable about the hip, and what's happening with the hip is is the idea that you took yourself to a class where you knew you'd have to do one-legged stuff in the bike on the spinning,
Mm-hmm.
and that it was going to bother you, but you also had this strong belief it was going to help you in the long run,
Yeah.
and that you needed, you know what I'm saying, because you were able to wrap your head around what I need to do to get this better for me, because just walking isn't doing it. I need to do
Mm-hmm.
something more. And so and you liked it,
Yeah.
so if somebody hates cycling, it may not be the best way for them. Maybe they need to do the step up, step downs,
Yes.
a bunch of times,
Yes.
because
Literally.
that jazzes them up more.
Yeah.
But the idea there is the loading would have been different for you doing step up and step downs on the stairs. We would have kind of, really kind of targeted that area a little bit better, and maybe would have paid a little bit more attention to how you were loading and maybe what you were avoiding with loading. If it's a hip tendon issue on the side of the hip versus if it's the anterior hip issue. And I think that has some stuff to do with it too.
Yeah.
You
Yeah,
know.
I agree.
Mm-hmm.
I agree. I think for me personally, my issue is a tendon issue.
Yeah.
I'm on the bike and I'm noticing I'm on the bike and I'm on the right side of the bike. I'm clipped in, but I am on the right side of the bike. Now, what does that do to the loading? I can't even load on my left side on a bike and I'm not even standing.
Right.
So for me, because I'm tuned into this stuff, so
Mm-hmm.
like you got to get over it. You got to get centered. I had a hard time
Right.
getting centered on the bike,
Mm-hmm. Right.
and
And so people without that kind of knowledge don't realize it till we
yeah,
kind of go in. And that's kind of where, it's helpful to have eyes that understand things, to say, that may get a little bit better if we actually kind of like force it to work a little bit more.
yes,
Because what we don't want to do is a lot of unloading on a degenerative tendon. That's not going to be helpful.
unloading,
That's like,
correct,
yeah, we want to actually
exactly.
get the loading going back again in that area. And, it's like Anthony Lowe talks about, people are chronically underloaded. But I think that, and that's true, but I think we also have to be careful of the, where they are in the physiological healing part. And, and I think PTs are good in that early stage of it. And I think we let our patients go way too soon. I think we really need to be, taking them through this, because this guy, if you had just done the first part and let him
Yeah,
go,
yeah,
and he would have had this pain going up and down. I mean, you stayed with him to see what else was going to uncover and what else happened.
yeah,
And then we're able to keep going and say, okay, we're going to modify here now, and we're going to do this now. This is better, but this is now showing up. And it was
exactly.
probably there all the time, and he was just doing all this other stuff, so he didn't have that going on.
Yes, yeah, yeah. And I think that, I'm not okay with 80%. I mean, for me, because, you treat a population who is active, you, you know, in my experience, when you load somebody and we underload I mean, there are people who I agree go way too aggressive at the beginning. Okay.
Mm-hmm.
But I think as we progress on, I think we as a profession underload our patients.
Yeah. Well, we have two, we've got people who do too much and people who do too little, and we need to like kind of bring it together.
Yes.
And do it, I think, a little bit more appropriatly. And I think
Yeah.
we've got a couple of comments here.
Oh, yeah, I can't
everybody's
see them
saying
still.
great. Everybody's saying great points. They like it. Great ideas. And Marcy, hi Marcy, hi Lindsay, hi Mate. Glad to see you guys here. She says, yeah, identification of the healing phase, and I think that that's really important. Is that if this is acute, like somebody, just really like something happened acutely, I think we need to like do the right things for the acute healing. I harp about this all the time with postpartum moms. Like, why do we treat them like they haven't had an injury to their pelvic floor, for God's sakes? Mm-hmm. Why are we not doing compression, ice, and protection? Mm-hmm. On that kind of stuff. But I mean, we need to do those things, and then as they're moving through that subacute phase, then it's important to get movement in and the right kinds of things that help and happen, and the parts, and they may not be ready for loading yet then. Yes. But they're definitely ready for movement, and they're definitely ready for stresses. But in my practice, I don't really see anybody very acute unless they're a dancer.
Right.
That's coming through. You see some more acute and subacute people than I do. Mine are already victims of, chronic unloading for a long period of time because they've gotten into the protection phase and never really moved out of it.
I
And,
know.
so they're the ones that are not bending their back. They're the ones that are not twisting. They're the ones that are not, sitting because they read in a magazine somewhere that they may have pudendal neuralgia and they should never sit, so, so the graded exposure piece is something that I spend a lot more time with,
Yep.
getting people to kind of like, well, what if we did it this way? Did that, but, because how is that different than this? And just getting them to kind of begin to understand that
Yeah.
it's safe, to
Yes.
start moving again.
Yeah,
Mm-hmm.
it's interesting because my population has gotten more like yours, and I'm realizing that they are chronically underloaded because
Mm-hmm.
it's acute's different, and we all have our acute issues, but the chronic under, and you don't realize that as whether as a new therapist or because you don't tend to really focus on why are they underloaded, and it's a lot of times it's just compensatory movement, but in my experience, when you start to load, it's a learning experience for the patient as well as you. 90% of the time,
Mm-hmm.
the longer they've had their issue, there's gonna be a secondary something or other that's gonna come up, and I will tell you 9 times out of 10 I see it
Yeah.
because and that's a good thing because I always tell my patients we've learned something today.
Yeah.
You're loading your system more than you ever have, and we learned that this is an issue now, and we will get you, or I will get you to where you'll be able to do that better or a better strategy.
Mm-hmm.
And I have a little sort of speech I do, but it's because of that, because they haven't been, if someone's standing on their right leg like this patient was, my patient, he's chronically loading that right side, and then I get him off his right side into his left side, after a while with the thorax work and getting him centered, no wonder the right hip, that side started to get a little aggravated again because
Mm-hmm.
I'm changing his strategies.
Mm-hmm.
And I had him jumping, he was playing basketball at the end of the whole treatment. He was doing much better.
Mm-hmm.
But I do believe that we have to expect as therapists, something's going to happen. You have to have in your brain at the first, I would say the initial eval, your initial assessment, areas of interest, whether they're your primary area that you're going to treat in or a region that you may be suspect that's going to come up later. We need to have that in our heads to expect that. And if it doesn't happen, fantastic. See you later.
Mm-hmm.
Goodbye. That's my opinion.
Yeah, that, things that happen, to me does not mean that we've done something wrong. It just means that this system is more complex,
Right.
and there's a lot that goes into the system, way more than just one single kind of directional approach, and we do this and it's all better. That especially when you're dealing with people who have had a chronic situation for a while, they've had decompensations and compensations and changes in movement system strategies that have all kind of gone in different directions in order to keep this person upright and moving. And so when we get in there and we begin to get them to start to change, oftentimes some other things will show up and people will look at it like, see, this is why I don't do that, because now all this other stuff is happening. It's like, no, this is your opportunity now to get this to change too.
Mm-hmm.
And it's your opportunity to get this a bit better too, so that you can feel more confident in your ability to move in different directions and do different things again,
Mm-hmm.
and get
Yep.
back to that, and get back to the things that you want to do, if that's what's important to them. For
Yeah.
you, riding on the bike was important. For him, he needed to get up and down those stairs.
Yeah. Yep.
He needed to. Yes, basketball was great. That was a joy that you were able to really get him to. But in the beginning, the functional limitation with him was like, I cannot get up the stairs,
Yeah.
and I have to.
Yeah. And I think it's interesting because and I look back on that as a learning experience for myself because I took him literally. Remember how we learn, in PT school, gravity eliminated muscle testing and things like that. This is years ago, but ultimately taking someone and changing their context. I know we've talked about this so many times, but for him, getting recruiting, getting him in a different position. I could have had him on his head doing hip flexion, but it was just in a gravity eliminated position, doing a movement that's relevant for him. And I will tell
Yeah.
you, I did put a TheraBand around him as the third phase in that. And initially it aggravated him again because he was over recruiting that rec fem and the psoas. And so I worked really hard on doing very baby steps in that tabletop position on the wall, getting him to activate the right muscles. And I spent time in there cueing him. I did tapping. I mean, I was really pulling from the neuro toolbox there to get him to really think about the muscles he was using. Almost like to wake them up. I hate to use that word, but they weren't working. So it was important for me to get in that position and spend the time, getting my hands in the hip flexor and in the abdominals and trying to get him to think of a different way, or maybe an imagery. I was giving him imagery up the wazoo to try to get him to turn that on. So he ultimately did fine, but his hip it got aggravated a few times after I thought I was good to go.
Yeah, and that's also part of the deal that goes along with a bit of sensitization.
Yeah,
is that you've got changes in the neural system.
Yeah,
you've got changes in the brain. You've got neurotags. You've got other things that are actually happening, and there may be a little bit of fear apprehension. There's so much to it all that sometimes people like that could look at a flight of stairs and go, oh boy, here we go. And that can set up the neuromatrix for like, well, this is what we do when you start saying that and you see the stairs, this is what we give you. Because we know you're worried about it. And so sometimes it just takes time. It's like, oh wait, we know this one, this is not going to feel good. And then but then he learned that he could get it to feel better. He could expose himself to it and back off and change, come back, do retest that system, get that system much more flexible, and get more variance in it, so that he could actually begin to with confidence take care of himself.
Yeah, and I think doing it in hip extension for him was like an eye opener. And I recently did just not a virtual, but consult with him, and we were talking about in the clinic getting him in a decline position, so almost like gravity eliminated. And because of his thorax, he would be in a decline position, and that would almost like decompress from the bottom up, and have him do bent knee raises in that position, because he had a decline bench at home. So we were just talking about other things in his toolbox he could do if it came back again. And he literally got pillows under his bum, he got pillows under his back, so he literally was in a decline position on his floor in his house doing like little hip flexion, just like he did on the wall, but it was just another way to do the same thing.
Yeah, you can take couch pillows and put them up underneath them, put their feet on the wall. If you've got a total gym at home, you can or a total gym in the clinic, you can put them upside down on it. And you can measure the degrees gym. or if you've got a plinth or even a plinth, if you want to put it up on some blocks or any of those kinds of things too. But I found having a couple of those cushions in the clinic work really well for getting people kind of in declined positions when we're working things differently. So okay, everybody, thanks for joining us.
Thank you, everybody. It was a pleasure, as always.
And we'll see everybody on the podcast.
Sounds good.
So, and if you have any other questions, leave them in the comment section, or if you're coming in and listening to this later, leave us your comments, and we'll come in and chime in our 2 cents.
And
thank you.
And also don't forget, our website is www.toughtotreat.com. We're in the process of making some changes there, but we've got some great clinical pearls, an opt-in on the website. So just feel free to, just check in there and give us your feedback. And it was great seeing everybody, and be well and stay safe. Bye.
Yes. Thank you. Bye.
Bye.